Good afternoon and welcome to today's webinar, Important Technical Aspects of the Venous Reflux Examination. My name is Kelly Baer and I'm the Creative Design Manager with Marketing Communications at IAC. Before we begin, I'd like to take a moment to review a few technical matters and let you know how you can participate in today's session. We would like today's webinar to be interactive, so we encourage you to submit questions. To do so, use the Questions tab located on the left side of your screen. Please submit your questions anytime during the webinar, as we will be monitoring questions throughout the presentation and will try to answer as many of them as possible during the Q&A period. Also on the left side of your screen is the Resources tab. Click on this tab for links to today's handout, a PDF copy of these PowerPoint slides. Select the file name to download the handout. Lastly, in the lower left of the player, please note the Request Support button. If you experience any technical problems during the course of this webinar, you may click this button. A technical expert will be there to assist you with any issues you may have. For those who like to take notes during the presentation, look to the right of the slides and click the Notes tab. There you will see a white text box where you can take notes on today's webinar. These notes will be emailed to you automatically at the end of the session. To be eligible for the SVU CME credit, you must be registered, logged into this webinar, then complete the survey. The survey will open automatically at the conclusion of the live session and be available from the IAC Pro Libraries website for 3 business days. If you are viewing this webinar in a group, please be sure you are also individually registered and logged into this webinar on another computer or device so that we have record of your attendance today. Today's presentation is being recorded and will be posted at a later time for on-demand viewing. This webinar is a joint presentation of IAC and the American College of Phlebology. And now I would like to introduce today's guest speaker, Diana Neuhardt. Diana is President, CEO of CompuDiagnostics, a multi-specialty diagnostic ultrasound company within the Phoenix metropolitan area. In addition to being an IAC Vein Center board member, she serves on the board of directors for the American College of Phlebology and is a member of the American Institute of Ultrasound and Medicine and also SVU. She is an advocate for patients with venous disease and has worked as a medical volunteer internationally for more than 13 years. With that said, I will now turn the webinar over to today's speaker, Diana Neuhardt. Diana?
Thank you, and thanks to all of you who are logged in and participating in this webinar. I have to say it's a little bit intimidating in a way to sit here and stare at your computer and talk to yourself. So I don't have any audience response to gauge my lecture by, so I can't really tell if you're falling asleep, so it's a little bit more difficult. So if I start jumping around or anything, then you can start worrying about me. But today's webinar is really something I think that many of you find interesting, and that's venous reflux exams. And they're also very challenging. And we know that all of ultrasound is very technical in nature. So the technical aspects of the exam can sometimes be intimidating to even ask questions about. So I'm glad you're here, and I'd be happy to be a resource at any time. I put my email there, and I'll be honest with you, you can email me anytime. I am not so faithful to responding to emails that minute, but I really do get back to everybody who emails me, that it just might not be that hour. So just by way of disclosure, I have no financial disclosures, but I want to mention that I am on the board of directors for the IAC in the Vein Center, and I serve as a liaison to the Vascular Testing Division. I represent the Society of Vascular Ultrasound, and these are volunteer participation. I'm also on the board of directors for the ACP. And that being said, I want to mention that my opinions expressed here are not necessarily the opinions of the IAC or the SVU or the ACP. Now, I'm laughing because they didn't know I was going to say that, but I have a voice, and so does everyone else in the audience, and we have a right to our opinion. And some of what I'm sharing with you is based on my experience and my opinions, and sometimes it may not represent what everybody else thinks. So that being said, I'd like to actually change the name of my lecture to the important technical aspects of the superficial venous examination and the evaluation of venous valvular function. And sometimes when we just say we're looking for reflux, we sometimes lose sight of the goal of the study, and it really has to do with many of the things we're going to discuss in this webinar. And so, keeping that in mind, these are the course objectives that we intend to cover today, and I hope that they will be clear as we move along, because many of these objectives are some of the things that, as we continue to gain experience in the treatment of venous disease, we recognize that some of what we did in the past may not apply to today or may not apply in the future. So we always have to be sort of cognizant of that, of the strategy of always trying to be on top of things. And that comes with attending meetings, obviously reading journals and magazines, but also communicating with your colleagues. And I think that's one of the best things about attending the SBU or the ACP meeting is that over the years, I've learned and recognized faces and met a lot of people, and so it's made it more fun to have the colleagues, and we can have some resources. Hey, do you know what this is or that? So feel free to label me as your colleague, and feel free to ask me any questions that you might want. And the whole course really is what I say to my grandkids when I drop them at school: learn something. This is part of a movie that I saw, and I just thought it was just really what they need to know. Just learn something today. And I hope we will accomplish that. So by way of introduction, my training experience as a venous sonographer for really more than 27 years has afforded me really a tremendous opportunity and to meet and perform literally thousands of diagnostic ultrasounds on patients, most presenting with acute and chronic venous disease, although I do other types of vascular ultrasound. But my tremendous interest has been in venous disease because I personally suffer from venous disease and have coagulopathy, and that gave me a DVT. So that was in my 20s, so I'm not in my 20s anymore. And over the years, and now with the chronic venous insufficiency, I'm always striving to, as a patient, recognize that what other patients feel too, and always looking for the answers. So my experience, but really volumes, has been written about this. There's numerous expert resources readily available for everyone in the audience. The internet is such a wealth of information, journals. And so we know that there's a lot out there, but many of us in our daily practice, including mine, we have patients that come in or present with disparate results, particularly when we're talking about venous studies. And often this is a consequence of people who are performing superficial venous exams that maybe have a knowledge gap in their experience, or they just really haven't had an opportunity to gain some of the knowledge that they need to know. And it's distressing to patients when they come in, and you find something that is really something that should have been picked up by other laboratories. So I want to talk about how we kind of try to move forward and standardize our studies and really move toward quality improvement. So my webinar is really based on two that have already previously been given, and I encourage you to view these. They're available to you, and the first one was given by Dr. Helene Froelich on the importance of the clinical exam of the patient with venous disease. And then Dr. Nick Morrison, he presented on ultrasound anatomy and nomenclature. And I'm happy to announce, too, we have one more of these webinars in this series on the way, and that's post-treatment assessment by Dr. Mark Meissner. So all combined, these four webinars should give you a sort of a brief but thorough overview of some of the topics that you might find helpful in your quest for knowledge. So I'm just going to give an overview of Dr. Helene Froelich's, and just summarize that it really begins, every ultrasound begins with a clinical exam. And not unlike any other ultrasound, but when you meet or greet your patient, you have to look at the patient. You have to really find out why are they there. Otherwise, you won't really know what you're looking for. You won't know where to really focus your attention. So you really need to look at the patient and also observe how they walk, because the calf pump function is so critical for venous return. And if a patient is shuffling along, that's going to give you a lot of answers of why they may have skin changes compared to maybe what you're looking for is valvular disease, maybe the patient just isn't having calf pump function. So some of that is so important. And also recognize that the CEAP classification, which is an acronym for clinical, which is C, etiology, anatomy, and pathophysiology. So this was designed by the American Venous Forum, a group of experts who really wanted to talk the same language. So when they called somebody a C2 patient, they know they were dealing with varicose veins. And so it was a really specific way to describe a patient. I encourage all of you to learn this and to really start thinking about that and putting that on your diagrams, that this is a C4 patient or this is a C5 patient. That'll be more revealing for the physician or anybody reviewing it. Oh, okay, then this is what the level this patient has. And it can sometimes help you say, well, I don't know, this patient's a C4. I didn't find anything. Maybe I need to look at some other images other than what I've done. And then Dr. Nick Morrison gave the venous anatomy. I'm going to cover a little of that in our pitfalls because I think that's something that a lot of sonographers struggle with is the superficial venous anatomy and what to call things. So we're going to talk about that later in the presentation. So by way of background, we know that duplex is probably the most frequently used investigation to evaluate chronic venous disease. And internationally, this is by the International Union of International Phlebology, it's rampant. There really is no systematic consensus from phlebologists, vascular societies, dermatologists, anyone doing vascular ultrasound and venous disease, how we should do it and when it should be done and so on and so on. So we know it's a problem. And we do know, too, that expertise and experience makes a difference in diagnostic accuracy, because every exam that you do is exam specific to that patient. So we want to have good outcomes when we apply therapies to these patients presenting with venous disease. And the logic is that we want to have the correct diagnosis and make sure that we're not overlooking something. So in my day, when I started ultrasound, the trend in diagnostic ultrasound was specialization, whether it be general radiology, cardiology, adult or pediatric, and so on. It really was more of that focused ultrasound exams. We learned a lot about the disease processes as well as the ultrasound itself. And we sort of see things kind of move away from that as we have more cross-training and we're required, due to economics and other reasons, or interest, that we do all kinds of exams. And so historically, when you were learning, maybe you created and developed your guidelines or your protocols, based on your general training. Let's if you were with the American College of Radiology, it was more of an anatomical based, whereas Society of Vascular Ultrasound, it was more Doppler-based, more of a physiologic study, and including the American College of Phlebology, which venous disease. But examiners created protocols that sort of maybe followed this process. And so you can see that now that we have duplex and we've married all these technologies, we might want to look back and think, well, maybe we've done it like this in the past, but moving forward, we might want to make some changes. I mean, the Society of Vascular Ultrasound has modified this suggested protocol that's on their website for members on the venous insufficiency exam. And it's a slow process because as you make changes, there's always going to be, why do we have to do that? Well, it's because we're learning every day. We're finding out things as we apply treatment and we follow patients, that there's a new way to do it. And so that's what's exciting about being part of the venous insufficiency exam and treating patients with venous disease is because there's so many new discoveries. We're really part of that next generation where we're going to really be able to help people long before they create or they develop skin changes or that the patient, their chronic venous disease maybe won't have the manifestations of maybe my generation or previous because we have a way to intervene sooner than later. So these protocols really help an individual. They are suggestions, but everyone makes their own protocol. And why do we want to follow a protocol? Well, I'm going to talk about this study later, but basically we all want to have high repeatability in the detection of venous insufficiency, and we want to have reproducibility. so that if somebody comes to my lab or your lab, we can definitely have at least the same outcomes and the same results. And part of this study showed that with educational intervention, we can accomplish that. And that's very encouraging. And so we can get standardization, whereas now when you really look at the studies, we only have maybe 70% agreement. Well, that's okay, but I think all of us would like to be more in the 90% agreement of what we see and so on. And some of that, again, is hopefully going to be accomplished by some of these webinars. So Venous Duplex has evolved. We all know that. Because originally it was designed at the diagnosis of deep vein thrombosis. And in my generation, believe me, nobody was trusting the ultrasound. They were all trusting the gold standard of venography. And in fact, whenever we had findings, the patient sometimes had to have a venogram to confirm that we even knew what we were talking about. So many of the protocols and the technology were really sort of geared around that. And we've additionally added some other things because it's a work in progress, because finally we had newer transducers where we could see more superficial. The technology expanded where we were like, oh, okay, now we can really look at the hemodynamics of the valves and the veins. So we can do this, we can do that. But we sort of built on what we already knew. And so that sometimes has its challenges because maybe it's not the best way. So we're going to talk about some of the protocols and really look and see where can we gain some better knowledge and maybe get rid of some of the things that we're doing. So we know that new venous therapies exist, but in the old days, in my day, vein stripping was the primary option for saphenous vein treatment. And so at that time, patients were not wanting to undergo a stripping unless they had saphenofemoral junction reflux. And so often, when we were just asked to evaluate a patient for insufficiency, that's all we had to look at was the saphenofemoral junction and also a saphenopopliteal. But venography was often used as a coordinating diagnostic tool. But that's because we used to believe that descending reflux was the objective, and it is. We didn't know there was ascending reflux. We only assumed, and the knowledge base was that of descending reflux. So venous mapping, as it's termed, expanded the scope of the ultrasound exam, and we now study venous valvular hemodynamics of the deep and superficial veins. I want to just mention the word mapping because, again, depending on who's in the audience, the word mapping can mean a lot of different things. So I really would like to abandon this term because mapping can mean so many things. In the old days, we mapped the GSV, or great saphenous vein. At that time, it was called the greater saphenous vein, the long saphenous vein, all kinds of things. We know the new nomenclature says it's the great saphenous vein. But we used to map the great saphenous vein for harvesting of for CABG, for coronary artery bypass grafts. And so we used to map that out on the leg, and then the doctor and the surgeon could come in and know exactly where it was. And so that was the meaning for that. Now we're mapping out veins to destroy in a different way, but the word mapping may not be the correct term. So maybe think in those terms, think in that way that the mapping could mean a lot of things to different people. We know that new knowledge exists regarding ascending reflux, which I talked about, in addition to descending. So we have to modify our current protocols because in the old days, like I said, we were looking at the saphenofemoral junction. Well, now we know that reflux can occur anywhere. It can occur in the saphenous vein, in tributary veins only, or non-saphenous veins that do not originate in the saphenous tree. So, and the saphenous veins can be referred to, just as a help, as when you're reading journals, the truncular veins. So the saphenous veins are within a fascia, and they're easily identified compared to tributary veins or non-saphenous veins. So now the IAC comes along, and they're trying to standardize your facility. And they have a lot of work ahead of them because that's a huge undertaking because we all do things different, and we're trying to create standards. So when you look at the minimum standards that are published by the IAC, some people would criticize that that's not enough. Well, I say that most people probably who are applying for accreditation are trying to be the best they can. So I doubt they're doing just the minimum. And in fact, they're probably doing the maximum. And I'd like to encourage you all to do the maximum, of course. But the minimum is just really what we observe that people do. So when you're getting accreditation for your facility, keep that in mind that you don't only do the minimum. You do what you think is appropriate for your patients. But the minimum standards are listed here. And this is right out of their document. And again, the minimum. Do we want to be minimums or do we want to be maximums? I think if you're the patient, you want the maximum done. And what's best for the patient is really to come up with the correct diagnosis. And I'm going to share some strategies of how we do that. It begins, obviously, like the front door, as I already mentioned. You've got to examine the patient visually. So the transverse compression views, which, again, began way back when, and that's with the transducer at the skin surface. So when I go back and I look at these, how do you get to the mid-femoral from the common femoral? Well, you can either just go there or just slide down every 2 centimeters and make sure there's no evidence for DVT or pleurolis or chronic DVT. So just because it says the one picture there, again, I don't believe that people just are going to be doing the minimum that they have to. Most people who are really trying to prove or somehow show that they excel are probably excelling more than we say. So this is just an ultrasound example, a still image. Again, this is a dynamic test, but we take still images. To the left of the screen is showing the common femoral vein and then with compression. So, and that's our anatomic survey, and that's really important when you're looking at veins, and I'll show some examples of that later. When you're in a longitudinal picture compared to transverse, you can sure tell a lot more about the anatomy. And so I encourage you that whenever you are looking at something to use both methods to examine. And that's how we see the fascia and the layers or the compartments of the veins as either the superficial compartment, the saphenous compartment, or the deep compartment. And these are our landmarks, and that's how we know where we are based on the fascia and other methods. So usually the transverse method is the best way to recognize that. And then the standards for spectral Doppler. Again, these are the minimum pictures. And I dare say if there were 20 that they required as the minimum, that is really just a bunch of images that have no meaning unless you're looking at a patient. So I could list every saphenous vein on here. I could list every non-saphenous vein. You should put tributaries, blah, blah, blah. But it has no meaning to take a bunch of pictures that really aren't relative. It really should be patient-focused, and that's what we're going to really talk about today, because that you want to have correct descriptors of where blood moves between the compartments, from the superficial either to the saphenous or to the deep, and then from the saphenous to the deep, because all of that blood is returning its flow to the right atrium. And so that is really what you want to describe in the study. How is it getting there? So let's talk about the first objective, and it's going to summarize some of this criteria for duplex ultrasound in the diagnosis of chronic venous valvular insufficiency. So begin by talking about the anatomy very briefly, and you can see by this image that there is a valve on the screen. And I'm just playing with my mouse, which is a little slower. Sorry. Okay. All right. So okay. There it goes. A little slower than me, and so by the time I use it, I can't do it very well. So saphenous valves in this vision, I mean, most people who are recognized can see the saphenous valve here, and they're bicuspid, there too, and they are covered by intima on both sides. So the ultrasound anatomy in the veins, we're really concerned about the valves. And saphenous valves, a lot of people ask me this question, how many valves are there? Well, this is based on postmortem exams, but basically around between 14 to 25 in the great saphenous, and at least 7 valves in more than that in the small saphenous. We know that valves increase in number as we're closer away from the heart, or farther away from the heart, sorry. And I just put this picture in so you can see the valves are actually turning both ways. And that's something to pay attention to, because if a patient has a valve that is not pointing towards the heart, that patient might have a venous anomaly or an malformation. So something to kind of pay attention to. So what do the valves do? Well, this is a nice cartoon that Dr. Helene Froelich lent me. And basically it helps produce blood flow in the right direction, and that's upward and inward. And so valve dysfunction results in downward flow as well. So it allows blood to go by both ways, or bidirectional flow. And that can obviously, over time, create a problem. And I want to mention, too, this is not an instant problem. And so we're dealing with a chronic venous disease. There's actually no cure for this, but there's a way to minimize the effects of it by treating veins. So that's the physiologic basis of what the veins do. And the valves help suspend this flow, and it's regulated by an energy gradient and pressure gradient. And just showing to the valves point to the direction of drainage. So reflux detection is venous valves. When they close, there's normally a reversal of the normal antegrade pressure. When they don't close, that's because there's an abnormal pressure gradient that occurs when valves are abnormal, and it allows retrograde flow. So the valves are not closing correctly, and that permits backwards flow, called reflux. So superficial reflux is determined when there's greater than 0.5 seconds measured along the time axis. So this is an example here of a spectral Doppler with color, and it's greater than 0.5, and I'm sorry I don't have it measured here, but along the time axis there is 3.6 seconds, so you can see that it's greater than at least 0.5. Now, longer than 0.5 is not necessarily a measure of worsening severity. It really has to do with the reservoir and the diameter of the vessel. So bear this in mind, that at greater than 0.5, it doesn't really, if it's 5 seconds, it is not a worsening of spectral reflux. So detection and measurement of reflux, how did we get that? Well, that came from a very brilliant guy, Nikos Labropoulos. He's published probably, 10,000 papers, or maybe I'm exaggerating, but he's a brilliant scientist. And so in 2003, he published this paper and presented his works at the American Venous Forum. And he talked about the definition of venous reflux. And basically, he used in this study, and I bring this to your attention, and I've quoted the paper, because if this is the criteria used in your office, you should figure out how they came to this conclusion. And they used a pneumatic cuff compression, and they measured other things as well. But basically, they came up with a cutoff value of greater than 0.5 is abnormal, and except in the femoral popliteal veins is greater than 1 second. And they also wrote in their paper that reflux testing should be performed with the patient standing. I know some of you are rolling your eyes, but I thought I would just bring that up to your attention, that that's how this paper was originally designed. I also talked about the duration of retrograde flow varies related to size, valve location, and number. And tributaries, like we said, the reservoir can influence that. They also talked about the active dorsiflexion, or how the maneuver we use to make blood flow was the only method they could determine reflux in a patient with edema. But we know by the UIP consensus document that there's really a lack of standardization in reflux assessment, especially when we're talking about post-treatment. And so in this case, in order to standardize methods, we should have patients standing, and we should come up with some type of value that we all agree on. So I touched on reflux theory, and I wanted to mention it in this lecture because in the United States, we do a lot of saphenous vein destruction, and surgically in the past, we did stripping. There are, in other countries, though, trying to preserve the saphenous vein, and so there are other theories that are applied to our methods, and that's because of the descending and ascending theory. Or did it start at the bottom and go up, or did it start at the top and go down? Well, now we know it occurs in both because of duplex ultrasound. So many physicians are doing what's called ASVAL, or it's a way of just taking out the large tributaries and keeping the saphenous, preserving the saphenous. And there's many claims that the saphenous vein might resume to normal findings, but not if it's at the terminal valve. So reflux theories really have altered how we approach patients presenting with chronic venous insufficiency, because we don't just look at the saphenofemoral junction or the saphenopopliteal junction. We know we have to do a segmental analysis of the saphenous veins, including the great, small, posterior, accessory, exterior. These are the 5 saphenous veins that are listed here. There's also non-saphenous veins, and these typically come from some type of pelvic source or perforator. And there's also tributaries of the saphenous vein, which can be just abnormal. So bear that in mind. So let me just finish that up. So when you approach a patient and you analyze when they walk in, you observe where the distribution of their varicose veins are, your diagnostic study should address those particular aspects of their leg. So if they're more lateral and posterior, you might think of a non-saphenous source compared to, it probably is not related to saphenous vein insufficiency. So you might have to modify your protocols to include these when the patient presents with manifestations in those areas. So now we're going to talk about the techniques or the methods we use to elicit reflux, because we know it's a pressure gradient. And this is how we really want to optimize standardization, is what technique should we use? And I'm going to share just my experience with you, how we do it in our office and why we do it in our office that way. And that's because we had numerous sonographers doing the same test. And so when we talk about superficial venous reflux detection, we have to have a method. So when you look at the literature, they talk about release after cap augmentation. Well, everybody, if you hold your hand up, we all know that we all have a different size hand. We have a different strength. Obviously, men usually have larger hands than women. And how hard you squeeze and where you squeeze, there's going to be tremendous diversity in how much pressure you're applying and what kind of impact that has to the veins. And also how long you squeeze. You're doing it for half a second? Are you doing it for a second? Are you doing it 2 seconds? Are you squeezing slow and releasing? I mean, just think of the variabilities of how everyone would do it. The pneumatic cuff inflation deflation device, this is one of the methods that we most commonly use in our office for the distal veins, because it does provide that standardization. Because I know that if I do the test and place the cuff, it will be the same as the sonographer comes right after me and places the cuff, and our findings should be about the same. Another method that is very helpful is the foot dorsiflexion relaxation. And if you think about that, that is a really good method because we're using that calf pump. The literature also talks about tipping a tilt table, and proximal veins using Valsalva. I'm a strong advocate for Valsalva maneuvers. We see a lot of patients with pelvic source reflux. I'll talk about that in a couple of minutes. And Valsalva is the most effective method for proximal vein valve, for the most terminal valve. I also mentioned the modified Perrotin maneuver. If you've ever seen me lecture, I've demonstrated how to do this. But essentially, the patient does their own movement. So Perrotin maneuver is really when the patient is standing upright and you just push them a little bit, or just apply a little pressure to them, and then their isometric movements will go back to stabilize their stance. But a modified is where you actually have the patient move themselves while you're scanning. This is a dynamic test, and the nice thing about the modified Perrotin is that you can actually see where blood comes from each compartment, and it really does answer the question a lot as far as what is the source of reflux and where does it come from and where does it go. So in our office, we do use, like I said, the pneumatic cuff inflation deflation device. It's handy. It also helps with ergonomics. We first begin with the deep system, and then we focus on the superficial. In our office, almost every patient is standing, and we have a step provided for them to have something to hold on to. They're elevated. The sonographer is comfortable. We also use equipment that has the ability to slide around and monitors move. So we've really addressed ergonomics because I think as sonographers, and you can tell, and I've sort of stated almost my age, that I don't have injuries because I do take care of how I'm scanning and pay particular attention to my body movement. And here's just an example of how we address the posterior aspect of the leg. Again, the patient's on a step. We have the ability to see. The bad thing about having a patient stand, and many of them, they get dizzy or lightheaded. I've had a few patients who almost faint. And I read an article one time, and I really, I wish I could remember who wrote it. I apologize. And they really postulated that it was really the audible. The patients are actually a type of motion sickness. They're looking at the screen, and they're hearing this, the Doppler sounds, and they're looking, and they see the red and the blue, and they think, oh, my God, that's my blood. And so just as a warning, when you're doing this type of thing, I tend to turn the volume down, and I also try to engage the patient. I have them not really focus on the screen to tell me about their kids and tell me about their life and so on, because the last thing you want to do is have somebody faint on you. But no matter how we do this, we know that every ultrasound is patient-specific, so we might have to make adaptations for every patient that we see. So one interesting study that I participated with, Dr. Fedor-Lurie, through the American Venous Forum, was called the INVEST study, and I mentioned this earlier, and INVEST stands, or acronym, for Investigating Venous Disease Evaluation and Standardization of Testing. And the real goal of this was to develop standard protocols, and 17 centers participated, and my center was one of them. And the great thing was that we actually got to get together, and we all basically went to Hawaii. That's where Dr. Lurie's office was at the time. And we all met and said, okay, this is how we're going to do it, and this is how it's going to be done. This is where you measure. And it was really interesting to, number one, meet more people and see how other colleagues do it, but to agree on how we're going to do it. And when we were together, it was really much easier to communicate that information. But we really were trying to do two things, and one is the repeatability. If you do the test over, what are your results going to be? And we had different combinations of time of day, same or not same reflux-provoking maneuvers, and so on. This is a very interesting paper if you want to take the time to read it. And the other thing was the reproducibility. If a different technologist did it, what would the results be? And it was, difficult on patients. Many, they had to come back, so it was sometimes hard to recruit patients. But it was a very interesting study and very revealing in some ways. And our office learned a lot from that, just on how much we maybe create our own repeatability problems. And so it really was a good communication issue for our office, because we really helped us discover what were we doing and how could we improve. So maybe this test might give you some incentive to say, if you have more than one person in the office, each of you scan the patient. How are you doing this? What are you doing? So that you can get that repeatability and reproducibility. But we had basically 57 patients. I want to point out, too, that these are all of the CEAP, so C2 is varicose vein, C3 is edema, C4 is skin changes, such as pigmentation, C5 is healed ulcer, and C6 is open ulcers. So we had a wide variety of patients, and maybe this wasn't the best thing because our numbers weren't really high enough to get some true meaning. But essentially, the repeatability, some of the things that varied, and basically time of day and patient position were the only two factors. And it was repeatable with standing. Reproducibility by different technologists, position of patient versus supine, reflux time was shorter when the patients were standing. And reproducibility in the morning. So it's kind of interesting how this could like I said, I really encourage you to read this paper because it really is revealing how much variability we have and what can we do to improve it. But the conclusion of the study really, and again, I know many of you are rolling your eyes, that the standing position, you want to have somebody using an identical protocol through an educational intervention, and you also want to somehow, if you can standardize your test, you will improve reliability. Let's just talk a little bit about the maneuvers and how can we standardize that. So I really discourage using cap augmentation. It's my own personal opinion. There's just too many variables. I think a really good method for standardization is the cuff inflation deflation device. Patient provoked obviously is a good method. Now Valsalva maneuver, and I show a picture here of a straw that is tied in a knot. So I know Valsalva is difficult to explain to a patient sometimes what you want them to do, but if you have a box of straws that left over from old vein mapping days, you can just take one of those and give a new straw to each patient and have them tied in a knot and have them blow that. And that is an easy way to standardize the Valsalva maneuver. So the last thing we're going to talk about are some of the pitfalls. And we could go on and on about some of the pitfalls that we're going to talk about, but I'm just going to really touch on them. So again, that you're aware of what are some of the things that you might be missing, or recognize, okay, now I know why I didn't detect this reflux because of these particular things we'll talk about. And the whole real aspect of pitfalls falls on the word duplex ultrasound. It's really a technology, and we're dealing with sound waves that are listed here. And I have Frank Mealy's book, Mealy's book, good friend of mine, and obviously brilliant guy who's lectured for years about ultrasound physics and instrumentation. But you can't use a device unless you know how to use it. You have to understand the physics and the instrumentation. So I really encourage you to really learn what you can. I know it can sometimes be daunting, but really take the opportunity to learn so that you can make your studies a lot more successful just based on knowledge. So a long time ago, Dr. Finberg, I actually trained in the facility where Dr. Finberg is a brilliant perinatologist. Dr. Finberg is a radiologist who works in a perinatology center, but he wrote this commentary, and I really embraced it because he talked about how ultrasound is difficult, that the person who is dedicated to ultrasound is really a specialist. Many of the ultrasound radiology exams are easy. But ultrasound, the image accusation is complex, operator-dependent, and it becomes the diagnostic process. And most importantly, in large measure, the one who holds the transducer makes the diagnosis. And we all know that's true. So because of that, we know that ultrasound has the pitfalls. It's operator-based, operator-dependent. You control the sounds, the buttons, and what's evaluated, which in red terms, yikes, especially if you don't know how to overcome some of those pitfalls. So here's one pitfall we all deal with. You can see this this is the great Saphen's vein. And the patient has lymphedema with sort of that cobblestone appearance, very characteristic for edema. So when we're using sound waves, we know that when sound is going to pass through that barrier, how does it get through that? And so we might have to adjust some things. We're going to have to change many things, including maybe what imaging frequency we're using. Maybe, consider that the patient, what are we doing? If we do a Doppler on this patient, we know that red blood cells are poor reflectors. So we might have to make sure that our range gate is open, that we have done things to really sort of be counterproductive to that, something that's getting in the way. And this is emphasized by Nico's paper that of the patients that had the edema, that those patients, they really experienced difficulty in determining reflux. So this was really validated by his paper, and you can just see by that image why that would be true. So you're going to have to do something to get around that. And we know that it's long been known that limitations for the duplex based on obesity. Obviously, if there's a cast, can't be done. An open wound is a little more difficult. You can put some, plastic saran wrap over it or something so that you have a barrier there and you're not over an open wound. But it is difficult, and limited patient mobility is secondarily a huge limitation. But so is the anatomy. The anatomy of every single patient is different. They all have some common denominators, but it's all different. And so when you're new to this and you're learning about the anatomy and you're learning about the variations, it can sometimes be a little bit frustrating. But it makes it more challenging and a lot more fun. Especially, I'll just share a few brief things that really might be of help. And one is about the great saphenous vein. That has the most variables in that we know that it falls into fascia, but often it will come out of the fascia. And so this is an example of it leaving the saphenous compartment. And earlier I really encouraged you to always use the transverse method when we talk about the compartment or talk about our anatomic survey. And here's an example of why, because actually this is an example of a vein leaving the compartment, the superficial vein. Sorry, I'm not very good at this. So I was going to show you where that little circle there is actually the great saphenous vein, and the larger vein that's coming out of that fascia is the tributary vein. And I'll show you the next example, or next discussion, and that's called aplasia, that's called hypoplasia. Aplasia is when there's no vein, and hypoplasia, or when the vein is hypo, or small, that it's small, but it's present. And here's an example that I've drawn out for you with the arrow of a different patient. And so it's a very common thing around mid-thigh that sometimes we'll have a large parallel tributary, and the great saphenous vein is hypoplastic. Often it can be aplastic, but often not. It's just that we aren't looking for the great saphenous vein and being so small. So that's one common weakness in our ability as we're learning to sort of identify I see now. And when someone points it out to you and you see it once, it just makes it much easier in the future to start looking in those terms when you see a large parallel tributary such as that. So, and then that's the vein, and you can see this a little bit better from the previous example, the longitudinal. And then the patient, you can see the very small, there it is. There's a small linear area across there. Sorry, I don't have a mouse. Here it is. Perfect. So that's actually the GSV down there and the tributary coming back into the fascia. So just bear this in mind as you're looking at saphenous veins. And the other thing that is brought to mind was talked about in the European Journal that endovascular surgeon Dr. Caggiati. He talks a lot about saphenous anatomy, and there's a lot of resources for you. And I encourage you to look at that and remember, too, that the accessory saphenous vein is another vein. So we're going to talk, too, about functional tests. That's an old school of thought, but actually functional tests give us some really important guidelines. And functional tests, such as plethysmography, this is an example of plethysmography tracing. And this was really discovering that the patient had had positive anatomy, that the refilling time was less than 25 seconds. So when the patient did this dynamic test where they squeezed their calf, and then there would be how long did it take for the blood to get back to its normal baseline? Well, if it was short, that meant that blood really never left the leg or the vein that you're interrogating, and that makes sense. So when you're squeezing, blood goes up and down. It's not refilling. So thinking counter in another way is, let's say it was normal. The refilling time was at least 25 seconds for it to come back, and so I bring this up because if you are scanning a patient and you are squeezing and you're kind of in a rapid way, if the vein was normal and you squeeze sooner than 25 seconds or 30 seconds, maybe you never gave that vein an opportunity to refill. And so I just bring that up. And then the other important tributaries of the vein, I'm going to show this to you, and that's pelvic source tributaries. So this is an example. You can see the color where there is reflux at the terminal valve of the GSV, but you can clearly see that there's no retrograde flow in the distal great saphenous vein, which is to the right of that. And so that's important because pelvic source reflux may drain and be abnormal, and this patient has terminal valve incompetence. However, the patient has a normal great saphenous vein. So it might just be at the terminal valve it's incompetent due to pelvic draining tributaries. So here's an example of that, and to the left of the screen is a patient doing a Valsalva in longitudinal. And so you look at that and you say, okay, well, that patient has reflux. Yes, they do. But if you go in transverse to the right of the screen and the patient does a Valsalva, you can see there to the left of the GSV a small tributary coming in, and that patient had pudendal vein reflux that then escaped through the GSV. So if you eliminate and just treat the GSV, but you never made note of the other reflux source, that patient may come in with recurrences much sooner than if you had identified the most proximal source of reflux. One other thing that is commonly misdiagnosed is the saphenofemoral tributaries, and that's the anterolateral branches, and also these are the draining tributaries, the superficial external pudendal at the gastric and circumflex iliac. But also there's posterior and lateral. These 5 tributaries typically drain between the terminal valve and the pre-terminal valve. So when you have reflux in that area, you must consider these as the source, and these are easy to trace back in transverse and see if they are the abnormality. One other vein is the accessory saphenous vein. The anterior accessory saphenous vein is anterior and lateral to the GSV, but it always lines up with the femoral vein. And so anytime you are in transverse and you see the deep system below, such as this image, you can see that the GSV moves medial, but the anterior accessory aligns up with the deep. So it's often misdiagnosed as the great saphenous vein, when actually it's not the great saphenous vein, it's the accessory saphenous vein. And so this is very important, particularly when you have 2 veins and you go to do some type of treatment, either with thermal or chemical ablation. It's very important that you're treating the correct vein, and if you've mislabeled or misdiagnosed the patient, obviously you're not making the correct diagnosis. And just a little bit about optimization of the venous reflux spectra. There's one to the left where you can see that the individual just never really adjusted their scale or did anything to improve the image. It's the exact same patient, just to the right of scale. And that's just adjusting the PRF or the scale. You may be adjusting the sample volume, just making it much more clear. And here's another example of that same thing. To the left, very ambiguous. What does this patient even have? Where the right is precise, and clearly this patient does not have popliteal reflux. This patient has a normal popliteal vein. So very important that we take the time to optimize our spectra so we don't have ambiguity. And this other example is really the optimization of the spectra. And I want you to look, this is the same patient. But the one on the left, the patient was diagnosed as having common femoral venous insufficiency. Well, you can see that they've actually inverted the image by accident, but really neglected to look. And below the baseline, you can see that it is a negative when it's correctly set up, because it's away from the transducer. So the baseline below is negative, and it should be negative, not positive. And so be careful, because sometimes you have to hit invert and sometimes you don't. And so pay attention to the equipment you're using and making sure that we use some sort of standardization of how we set up our spectra and where it should be. And how to diagnose this, troubleshoot that if you don't. I mean, one easy way is to just go back up to the artery and to see which way that's going and adjust it that way. Some other things that can influence our findings in the lower extremity include diseases of the abdomen and pelvis, including the liver, left renal vein compression, which is called nutcracker syndrome, and that's the superior mesenteric artery. Iliac vein compression syndrome, known as May-Thurner syndrome, and there is May-Thurner anatomy and May-Thurner syndrome. So there's individuals who are predisposed to the anatomy, but they don't necessarily have the syndrome, which is where the iliac vessel, the artery compresses the vein, and over time it creates some webbing, and it can influence the patient, particularly left-sided findings with patients with edema. So maybe do a little extra study on some of these things, but also the dilated ends of uterus and ovaries, called pelvic congestion syndrome. And pelvic insufficiency is typically called more the extrapelvic varicosity, so in that lower pelvic brim. And patients with hemorrhoids, they could have posterior thigh varicose veins. And all of that, obviously those can all influence your findings, and be aware of this as you're looking in the legs. And one last note, talking about perforating veins. The important role of perforators, we have yet to discover really the role and what we should be doing. And I caution individuals to really think about the flow channel between the compartments and what these perforators do. And more often than not, they are actually normal perforators, more or less referred to as a reentry perforator. How does flow get from the skin? How does flow get from this compartment? Well, it's through these perforating veins. And often if the vein is dilated, it may be related to the column of blood that it's feeding. So I caution you to really think twice about how we're doing it in outward flow. We think about net flow. So during systole, or when the patient squeezes their calf, does flow come out of the perforator? If during relaxation flow comes in the perforator, that's normal. And if you have more going in than going out, maybe it's a functional perforator. So I just really want to caution that we don't, every day we're learning about the value of perforators and what their role is. And so when you think in those terms, just maybe consider your technique and really pay attention to which way the flow is going. So in our diagnostic assessment in summary, it's really, as I said, there's got to be a reason why you're seeing the patient, so you must identify and understand why they're there, and they should be an explanation of the distribution of varicose veins on the skin should really correlate with the findings that you have with the ultrasound. So in conclusion and summary, these were the objectives that we did, and really I just want to emphasize that standardization in the vascular lab, in the venous laboratory is possible. We just have to recognize the pitfalls that can happen and try to overcome those. And as colleagues and societies, we move together, I'm certain that we can accomplish this. And I thank you so much for listening.
Okay, thank you, Diana. And at this time, we'll begin the Q&A session. From IAC Vascular Testing and Vein Center, I'd like to introduce Marge Hutchison, Director of Accreditation, and Laura Henson, our clinical specialist. Marge and Laura will assist with the Q&A session today. Marge, would you like to start us off?
Thanks, Kelly. I just want to say that if we don't get to your questions, we will get a printout of them in a few days, and each one of you will get a personal response back from us. So don't think just because we don't read your question here that we're not answering it. The first question, Diane, is can diameter measurements be obtained in long axis at the saphenofemoral junction?
Diameter measurements as a standard are always obtained in transverse view, always.
Thank you. Can diameter measurements be documented in millimeters?
They can. The problem with anything you do, it should just be your standard, and typically it's some of it is influenced by, let's just say that local carrier determination. If you say that something is 5 millimeters, but their determination reads 0.5 centimeters, you may be confusing them. So it's probably best to even consider what does the local carrier determination want, and maybe put it in that format. But typically we do measure in centimeters.
All right. just a few more questions because we're kind of out of time, but when obtaining spectral Doppler waveforms at the saphenofemoral junction, should it be taken at or before the terminal valve?
Well, the terminal valve is a little bit variable where it does unite with the deep system, but it's very important that you actually survey before the terminal valve, because that's assessing terminal valve, and between the terminal valve and pre-terminal valve. And what I really like that people are now looking for the valve, because again, this is a valvular study, and the last valve is called the terminal valve. The valve previous to that is the pre-terminal valve. So you are actually in the femoral side of the terminal valve when you're assessing the function of the terminal valve. And the pre-terminal valve, in between those two, that usually is between 2 to 4 centimeter area before you see the pre-terminal valve, and you should be assessing in those areas. And that can be revealing whether or not the patient has terminal valve incompetence. May actually have different meaning than somebody who has pre-terminal valve incompetence.
Okay, one last question. There's a ton of questions, and it looks to me like every other one says, does the patient have to stand?
The patient doesn't have to stand, but if you want standardization, yes. But standing, what it does is optimize the gravitational impact to the vein. There's some patients who can't stand, let's face it, and there's some patients who are dizzy or lightheaded. But I think you should recognize how that might influence your findings, and also it should be noted that the patient didn't stand. Because that way, if, let's say, the lab next door does the patient 2 months from now or next week, their findings may be different because maybe they did have the patient stand. So when we talk about repeatability, that's really important. But, there are patients who can't stand. But what are you going to do about that patient? If they can't stand, does that mean they can't walk? And maybe that patient's not really going to, go through any type of venous therapy. So keeping that in mind is, I think, key. What's practical is practical. So, we don't have to, be a purist. We just have to think practically and what's best for the patient.
Okay. Well, thank you, Diane. I appreciate all the effort you've put into this project. Diane has been instrumental in the other webinars as well, so thank you very much for your time. Kelly, do you have any closing things?
Okay, great. Thank you, Marge, and thanks again, everyone. And a very special thank you to Diana Neuhardt. Feel free to contact IAC with any questions that were not answered during the Q&A session. Just a reminder that today's webinar is session 3 in our 4-part series. Join us again on Wednesday, October 21st for our final session 4, Important Aspects of Post-Venous Treatment with Dr. Mark Meisner. Visit the IAC website to register. To receive continuing education credit for attending this webinar, please complete the survey. The survey will appear on your screen automatically at the conclusion of this live session and also be available from the IAC Pro Libraries website for 3 business days. In the upper left, you'll click on My Webinars, look for the title of this session, Important Technical Aspects of the Venous Reflux Examination. Beneath this title, you will see the link Take Evaluation. Click this link to complete the survey. Your certificate can then be accessed and printed from the very next screen and any time thereafter through a new link on the My Webinars page called View Certificate. If you have any questions about the survey, please contact us at webinars@intersocietal.org. Once again, we thank you all for joining us today and appreciate your participation.